All right, good evening. Hello guys, how are you? So I'm going to make a video for pathology, and it will comprise cases or pathological cases that I have, and then I'll be able to answer them. I read the question and start answering the questions like that, and then I will be able to share the video with you guys on Telegram. So thank you so much, and hopefully you enjoy the video, and wishing you good luck. Let's go. All right, so we have got the first question, case number 1, which is saying the lead. Case 1, a 60-year-old diabetic male. So we need to highlight something that is important. So a 60 is a very good point. A 60 years old diabetic male, one diabetic and male. Those are what's this? The points that we need to take note of. With a history of hypertension, point number 4, presented with severe retrosternal pain, the pain behind the sternum, radiating to the left shoulder. Radiating to where? To the left shoulder. Radiating to the left shoulder. And the laboratory investigations showed elevated serum troponin. So after you do the laboratory investigation, you find out that the serum troponin or the blood troponin and creatinine phosphokinase are elevated. So this case scenario is full of statements. It's full of positive statements. And for us to understand what they're trying to say, we need to know the condition that the patient has presented with. And how do you know the condition of the patient or which the patient has presented with? We need to know the clinical presentation of which condition under cardiovascular. So if you really look at this question, at this scenario, you'll find that the most significant things have been highlighted, and you have diabetic male with history of hypertension who presented with a pain, severe retrosternal pain. They have even described the pain. It's behind the sternum, which was radiating to the left shoulder. Laboratory investigation showed elevated what and what. What is your diagnosis? That's the first question. So I will tell you that the diagnosis is myocardial infarction. That is the diagnosis. How did I know that? So for you to know how I came to know that, I have to take you to the topic so that we do it I do it in less than 5 minutes, then we go to the other topic or to the other question. So what is your diagnosis? Mention the risk factors of this disease. We need to know the risk factors. Describe the microscopic picture of this disease, then enumerate the possible complications, of which all these are going to be covered in the tutorial, or let me say rather in the they will be covered in the discussion. Yeah, in the discussion as we go on. So this is the book I'm gonna open, and this book is called Is Pathology. It's special because it is straightforward. So now I would like to start from atherosclerosis before we do the myocardial infarction, because atherosclerosis is what leads towards this, to myocardial infarction. That's what you should know. So now what you need to know is that atherosclerosis is a progressive disease, meaning that it does not just occur at once. It is a progressive disease which affects small vessels and large arteries, of which by now we know which ones are small and which ones are large arteries, characterized by lipid deposition in the tunica intima, followed by the thickening and the calcification of the vascular wall. If I was to draw the vessel here, so that I make you understand. If I was to draw the vessel, this is the vessel. I'm going to draw all the layers. So let me just pause the video. I don't want to waste much of your bundles. Now imagine this is the tunica intima. This is the tunica intima here. This is the tunica intima. And then this is the tunica media. Just imagine like that. This is the tunica media. And then this is the tunica externa. Yes, tunica externa or tunica adventitia. So these are the layers of the blood vessel, of which this is the lumen. I'll put the letter L inside. This is lumen, the lumen. So now in atherosclerosis, what happens is that there is a deposition of lipids in here in the tunica intima. There's a deposition of lipids, collagen, and the cells go there like the macrophages. When they go there, what happens is that the macrophages will start eating up that collagen that is there and the lipids. And when the macrophages swallow that lipid, they are no longer called macrophages, but they are instead called the foamy cells. I want you to understand this properly. They are instead called the foamy cells. So foamy cells are really the macrophages that have swallowed the macrophages that have engulfed the lipids. So the macrophages that have engulfed the lipid. The macrophages the macrophages that have engulfed the lipid is called the foamy cells. So when the macrophages move from the blood here, then they go in the tunica intima. They will start eating up the collagen and also the lipid that is deposited in there. So the lipid is deposited there because maybe there's an injury to the blood vessel. Because there's an injury to the blood vessel, lipids are able to move from here and they are getting deposited in the tunica intima. And that is what is leading to atherosclerosis, forming what is called an atheromatous plaque. And that plaque is nothing but really the lipid that has been deposited in there is called an atheromatous plaque, atheroma or atheromatous plaque. It will be deposited in the tunica intima, and then the tunica intima will start, like, that will lead to a reduction in the diameter, or rather the largeness of the lumen. The lumen will become very smaller, so it will be allowing a little amount of blood to pass through it and reach a certain organ. So what I want you to understand is that under atherosclerosis, there's a deposition of the lipids in the tunica intima, and when the lipids have been deposited in the tunica intima, there's calcification of the vascular wall. Because when a lipid is deposited in here, in the tunica intima, it will start bulging, it will start going, it will start occluding the lumen of a blood vessel. Once the lumen is occluded, there will be diminished blood supply to a certain tissue. That is what I want you to remember. And there are a lot of things that predispose to people having that atheromatous plaque. And these are the risk factors that they are trying to tell you. The incidence is that it occurs mainly in men and women. And the age is mostly greater than 45 or 65 years. Mostly they use 65 years. So now, for the risk factors, how do you know the risk factors that predispose to the formation of the plaque in the tunica intima? Those are the risk factors that have been highlighted. And now the risk factors are divided into two. You have what are called the modifiable and non-modifiable risk factors. So what does it mean when we say non-modifiable? It means that these ones we cannot control it. For example, we've just stated that men are usually more affected than the women. That means that we cannot change that fact. It's a fact. So that one is not non-modifiable. We cannot modify it. We cannot change it. It's a fact. That is what you need to know. It is a fact, so you cannot change it. So non-modifiable age, for example, if you are 65 or greater than 45, you are predisposed to having atherosclerosis. It doesn't matter whether you are what, but that age is important to remember. It's a risk factor, and it's a non-modifiable risk factor. Sex, male. Being male is a risk factor for having or developing atherosclerosis, and we cannot change that one. So it's non-modifiable indeed. So they are saying there is increased risk of developing atherosclerosis after menopause in women. But remember, most affected are male and are men. And the ways ask you those questions, state the risk factors. So you tell them the risk factors are divided into two. You've got non-modifiable ones and the modifiable ones. Family history. If there's anybody in your family who has got a history of atherosclerosis, just know that you are also predisposed. And that's not a lie. It's a fact that we need to put into consideration. You cannot change it. That is why it falls under non-modifiable risk factor. The other one is, for example, if you've got familial hypercholesteremia, like in your family, you just have that disease of having a lot of cholesterol. You are predisposed. But remember, if you have got hypercholesteremia, you need to differentiate it from what they're saying, like familial hypercholesteremia. This one is a familial thingy. It's not like you have got that hypercholesteremia alone. It's different. Those ones are falling under what you call the non-modifiable risk factor. So we move from the modifiable ones. We move from the non-modifiable ones to the modifiable factors or modifiable risk factors. Guys, these ones, you have to know them. Guys, you need to know the risk factors for atherosclerosis, because atherosclerosis is the same thing that is leading to the myocardial infarction that we discussed. Just imagine if the occlusion is occurring in the coronary artery. It means that the myocardium won't be supplied with blood, and hence, what happens? You start having that chest pain because there is just oxygenation to the cardiac myocyte that is bonded. So now, how do you remember the major risk factors, or not the major, sorry, the modifiable risk factors? So for all the modifiable risk factors, as the name suggests, modifiable, it means that you can control it. You can control it. So you have got the major 4H. So the major 4H there, or H's, there you have got 4H's that will guide you on the things that are modifiable, the ones that you can control. Hyperlipidemia, for example, especially if you have got low density lipoproteins. Remember, low density lipoprotein molecules are also called bad cholesterols because of the way they do their function, in the way that they transport fats from the liver, taking it to the all parts of your body. That is why they are considered to be bad cholesterols, because when they are deposited in the all parts of your body, they will lead to atherosclerosis or ischemia because they occlude the blood vessels. But HDL, the high density lipoprotein molecule, they are good cholesterols because they carry lipids or other fats from the peripheral, taking it to the liver for metabolism. That is why HDL is regarded as a good cholesterol. But remember that there are 4H's. So you've got hyperlipidemia being the first one. We can control hyperlipidemia. We can insist on taking the things that are rich in lipids or fats, or we can just manage that hyperlipidemia. Maybe if you, for example, you've got hypercholesteremia, we'll give you the drugs, the statins. So hyperlipidemia, we can control it. Hypertension. So hypertension, you can control hypertension by giving you antihypertensives. So you can control that. Those are modifiable risk factors. Hyperglycemia, which leads to diabetes, which is in brackets put as diabetes, it leads to hyperlipidemia. Remember, the mechanism is straightforward. Because your body does not read, it tries glucose, so it will start breaking down the fats, which will lead to hyperlipidemia. So hyperglycemia is also a risk factor. Heavy smoking. This smoking, what it does is that it induces vascular damage. It damages the vasculature, directly damages the vasculature. So that is why we're saying for the modifiable risk factors, you've got the major, sorry, not the major, but you've got the modifiable risk factors and the non-modifiable risk factors. Non-modifiable, you can't control it. Family, age, sex. Those you cannot control them. The other one is modifiable. The modifiable risk factors, we are saying that we can't control them. I mean, we can control them because they are modified. You can modify them. You can control them. And examples, you've got 4H's that fall under the major risk factors. 4H's, of which there is hyperlipidemia, hypertension, hyperglycemia, and heavy smoking. That is why when we are taking a history, we need to ask about all these because they're important. They're important for us to know. You ask a patient, were you diagnosed with hypertension before? Have you had any history of hypertension? Is there anybody in the family who has presented with a similar illness? Because you are trying to ask about the risk factors. You want to determine if at all that patient is predisposed to the disease. But remember, we've not yet started talking about myocardial infarction, or rather ischemic heart disease. We are discussing atherosclerosis, which leads to that, and it's the most significant pathogenic mechanism that has been postulated, or that has been had. That, guys, I was taking some water. So you need to think in those areas. So it's a theory that has been approved to be like the most significant cause of ischemic heart disease. If people stop smoking, hyperlipidemia and smoking increase the risk factor in the age less than 40. Somebody who has got lipids and they're less than 40 like me, and I'm smoking, I'm predisposing myself too much to atherosclerosis. But remember, heavy smoking, heavy smoking. So you also have a minor under the modifiable. These are things that we can control. Sugar intake, you're taking a lot of sugar. Steroid intake. What does steroid do? So steroids, these are for example, how can I explain this? Okay, I'll explain a little later. At the time I'm going to remember this. Stress, type A personality. These people are just always busy. They are doing this and that. They're always stressed. So stress is one of the risk factors. Sedentary lifestyle. You don't even exercise. You're just seated there. You're just seated. You don't exercise. You don't do whatever. All you just do is eating. You just eat. You just eat. You just eat. You just eat. Sedentary lifestyle. these are the risk factors for atherosclerosis, for developing atherosclerosis. You have got modifiable risk factors and non-modifiable risk factors. So for modifiable, we've already talked about them. We are saying that these are divided into the major 4 H's and the minor 4 H's. So 4 H's, you have got the first H, which is for hyperlipidemia. The second one is hypertension. The third one is hyperglycemia. The other one is heavy smoking. Minor, you have got 4 H's, of which you have got a lot of sugar intake, steroid intake, stress, state lifestyle, and the sedentary lifestyle. And then the non-modifiable, the ones that you cannot control. You cannot control familial history, to sex, for as long as you are male, you're predisposed. Third, the age. Always remember that you'll be asked that. So what is the pathogenesis? What is the exact mechanism? So the pathogenesis is not known. The exact mechanism that is behind that is not well known. So now there are a lot of theories that have been postulated. So I won't waste too much of my time explaining the whole theories. I'll just take you through the theory that has been accepted and of which the so let me just so the one that has been said to be the cause is the first theory here, which is called the insufflation theory, or aka or also known as response to endothelial injury. I'm sure by now we know that whenever we injure the blood vessel or the endothelium, what happens is that there's raising of those factors that will lead to thrombosis, so that it cover up the thing that has been damaged already. We know that by now. But that is the theory that has been postulated to cause atherosclerosis. That is why they're saying the mechanism is exactly not known, but the response to endothelial injury, aka insufflation theory, is the one that has been postulated to be the most significant cause of the developing of an atheroma in the tunica intima. So endothelial injury is the first one. When the endothelium is injured, the lipids will be what? Will be deposited in there due to a high blood pressure. For example, like I drew something from the very beginning. So I was saying, if this is the blood vessel, this is the lumen of the blood vessel, and this is also another layer of the blood vessel, and then you also have this as another layer. Sorry guys, I'm not good at drawings. Yeah, it has gone beyond my imagination. So this is the lumen, and then after the lumen, this is the tunica intima. So this is the tunica intima. After the tunica intima, you have so if this is the lumen, what happens is that due to a high blood pressure moisture, and the high blood pressure, remember, is the most common cause of it's also one of the causes of endothelial injury. So when the endothelium is injured, the one that lines the tunica intima. Remember, the tunica intima is the one that is lined by the endothelium. Now that endothelium is injured. When it is injured, the lipids that are flowing in the blood vessel, because of a high blood pressure or hypertension, they will be deposited in the tunica intima. That is why hypertension is a leading factor that predisposes people to having atherosclerosis. It's because of that. So due to high blood pressure, because there is a deposition of the whatever in the tunica intima, of the lipids in the tunica intima, because of the high blood pressure, what happens is that will attract the macrophages. Macrophages will come here. I will change the color for the macrophage. I'll say it's black in color. If this is the macrophage that has gone there, that is a macrophage. That is the macrophage there. That is the macrophage that has gone in the tunica intima. It will start ingifying the lipid that is there. When the lipid is ingified, the macrophage is no longer called the macrophage, but rather it's called the foamy cells. This is the foamy cell I was talking about. That will lead to lipid oxidation within there, the macrophages and the other areas. Lipid oxidation will lead to further damage of the endothelium. That will lead to platelets, macrophages. Remember, the platelets are also there. They're trying to cover up that injured blood vessel, injured endothelium. That will lead to the platelet and macrophages secreting the cytokines and other factors that will bring about inflammation and also the proliferation of the tunica intima. because the tunica intima is being damaged, what happens is that even the tunica media will be affected a bit. So the tunica media will undergo what? It will proliferate. The smooth muscle cells, which is the tunica media, will start proliferating, and the smooth muscle cells will start detaching, moving from where it is, going in the tunica intima. That will bring about a thickening of the blood vessels. It will be like this, sorry. It will be like this. This is how it's going to be thick. To be thick. That is why it is called atherosclerosis. If it's when it fixes like that, what it is called an atheroma. Or at first it is called the fat streak. Fat streak. FATTY. Fat streak. STREAKY. Streak. Fat streak. So this is our at first that is why it is that is what it is called. And then after that, after the proliferation and the scarring, it is no longer called the fat streak, but rather it is called the atheromatous plaque or an atheroma. An atheroma is formed, and that an atheroma is formed of the smooth muscle cells, the macrophages, the platelets, and the other things that were invited in the formation of that lipids and the atheromatous plaque. They will occlude the blood vessels. Now, imagine if the blood that was going to the tissue was full diameter, but now it's going halfway, or maybe 75% of it has been obstructed. So you're going to have a little blood reaching the tissue. And that is what causes atherosclerosis. So now this thrombus, or rather the atheromatous plaque, it can either detach or remain there forever. And that we'll come back to that. We'll come back to that. So excessive vascularization of the wall, you're going to have blood vessel reaching here, of which that is not helping at all. Of course, it's more like a compensatory mechanism, but it's not helping at all. So that is the theory that you need to know. I don't want to talk about this theory because it's not accepted. It's just one of the theories of which you can read about it. I like that one, the first one, because it's the one that I was introduced to by my lecturer, Dr. Nularindo. So now the sites. What are the commonest sites for the atherosclerosis? Number one, we've got the large arteries and the small arteries. Remember, we said they affect the large arteries and small arteries. Number one is the aorta and the coronary arteries, as well as the cerebral arteries, carotid arteries, mesenteric artery, renal artery, and the popliteal arteries. These are the commonest, but the ones that have been highlighted, the aorta and the coronary arteries, are the most commonest sites for atheromatous plaque, meaning that if it is in the coronary arteries, it means that the heart will be stuffed with blood. Cerebral, meaning the brain, you're going to have a stroke. If it is the carotid, it's to a stroke. Mesenteric, it means that you're going to have an ischemia to the bowel, the GIT. Renal, it means that the kidneys will die off. The popliteal, it means that your organ will be affected. That is those are the common sites for that. But they are more common in the ostium of the artery due to ostium, meaning we know the ostium artery due to hemodynamic current in the atherosclerosis. Ostium artery is found should be in the bone marrow. What is the morphology? You've seen what I said. So at first you can see it. You can see it as yellow, and that thing is really, really small, and it is more common seen in children, or rather in the young, not children. Let me use the word in adolescent, adolescent, maybe, adolescents, and from young people to 20 years. That is when you see the fat streak. Remember, I told you that it will remain there at least for some time. It's the first thing that you see before you see the atheromatous plaque. And there's a question that comes. So the fat streaks, they are seen in what? Not necessarily in children, but they are common from children from the childhood age to 20 years. That is what I want you guys to understand there. Those are called the fat streaks, and those are the things that you are seeing there, the yellow things there. And then the gross, what do you see? Gross appearance of the fat streak. It's yellow, like I mentioned it, and it's flat, and it's common in the aortic orifice, in the openings of the aorta there. This is the commonest site. These are MCQs. If you did apply to CVS, you would have appreciated this so much. Micro, what can you see with a microscope? So clear fat clefts, foamy cells, you can see them. The foamy cells, these are just macrophages that have engulfed smooth muscles, and the lipids. Or rather, we can say the macrophages themselves, plus the smooth muscle containing the fat, all of them are for the form what is called the foamy cells. After that, because remember that one was common in adults, you can have what is called an atheromatous plaque or an atheroma. So now that atheromatous plaque, it is the one that you are seeing here. This is let me just do that so that it stops disturbing my coding. So this is the atheromatous plaque. You can see it. This is it. This is an atheromatous plaque. It's formed. You can see it even has a layer here that's formed. This is the tunica intima that has been deposited with smooth muscles that were coming from the tunica media, the macrophages. You have the cells like which ones? The macrophages which were engulfing the lipid that was deposited in there, forming the foamy cells. And this is the lumen that has remained. So meaning that this tissue is going to die. It doesn't have oxygen, the tissue that is where this artery goes. So you can see the white film cap. This is the white film cap that you are seeing. Somewhere there, the cap, the white film cap is there. Film. You can even see it. With the yellow soft core. This is the yellow soft core. You can see this is the yellow soft core. The cap is there. Microscopy, you can see the fibrous cap. Meaning you can, but gross, you can see that fibrous. I mean, micro, you can see a fibrous cap using the microscope. That is about the atherosclerosis. You can see also macrophages under the microscope. You can see also the proliferated smooth muscles and the collagen in the intima. Remember what I told you, the collagen is also being deposited there. Lipid core, what can you see microscopically? You can see the foamy cells, needle-shaped cholesterol clefts. Those are the needle-shaped cholesterol clefts. You can see them. Dystrophic calcification, the basal zone, you see the smooth muscle and the connective tissue. There is vascularization. In short, there will be like some blood vessels coming there. So now, if you can see very well, this is what has happened. This is the atheromatous plaque. This is it. You've seen the way it is. So it will obstruct the lumen. The lumen is going to become very, very small. And hence the blood that will be going, for example, to the carotid artery is going to be very minimal. So the brain will be starved. You're going to be exposed to the things like stroke and the likes. That is what I want you to know there. So what are the complications of atheromatous plaque? This is an atheromatous plaque. This one. So atherosclerosis is the formation of an atheromatous plaque. How is an atheromatous plaque formed? We've already talked about that. It's a pathophysiology response to injury. Hypothesis is also called insufflation theory. So what are the complications of the acute complications of atheromatous plaques? Number one, if thrombosis can detach. So on top of the atheroma, what happens is that thrombosis is the formation of the thrombus. So you find that just on top of the atheromatous plaque, because there is an occlusion there, the blood cells won't be moving properly. So they will start stuck in there. When they stick there, what happens is that they won't be able to pass, and hence that will develop that will lead to what? Thrombosis of formation of the thrombus. So you are going to have the thrombus there. That is the complication, number one, due to end injury and ruptured plaque. Sometimes the plaque can rupture. If it ruptures and goes somewhere, there where it will remain, it has injured the blood vessel, and hence there will be thrombosis. Those are risk factors, and they like them. So TUH, ulceration, you can have if it detaches, for example, here it has moved, you are going to have an ulcer. Even here it has detached, yeah, it has left an ulcer there. So ulceration and detachment. So because they have detached, the lipid has moved, it is called a cholesterol emboli. Hemorrhage inside an atheroma due to weak. Remember we said there is a development of blood vessels in there inside the same plaque, but because they are weak, they can detach. When they detach, what happens that will lead to bleeding due to weak vascularization and thin fibrils, and that will lead to sudden occlusion and detachment. So due to weak vascularization, there is no blood that is reaching the same area, so they will form they will detach. When they detach, that will occlude the smaller blood vessels that are in them inside the atheroma plaque because of the lipid that is there and whatever, and there's weak vascularization that will lead to what? To reduce blood to the worst is an atheromatous plaque, and hence that will lead to bleeding or detachment and the likes. What are the other complications? These are acute complicated atheromatous plaques. Acute complicated, sorry. And then you have got complications. These are complications. Large arteries that can lead to aneurysms. This is an aneurysm. Aneurysm is that the dilatation of the blood vessel. Abnormal dilatation, abnormal permanent dilatation of the blood vessel. So it will dilate. Remember, if here, for example, here it is, if the blood vessel is blocked like that, it means that no blood nutrients is going to the wall of the blood vessel. We need to know that even the blood vessel itself is also supplied, but because it is not being supplied here, it will die off. And if it die off, the tunica media becomes weak and it dilates. That is what is called an aneurysm. Sorry, here I think I misled you a bit, but remember what I mentioned is that these are acute complicated atheromatous plaques. So you have got thrombosis, it can be formation of thrombus, ulceration, and hemorrhage. Remember that. But here for the complications, remember you've got aneurysm and neurothrombus, of which the neurothrombosis is really clot formation within the blood vessel wall. Within the blood vessel wall, they start forming the the thrombus. Small and medium-sized arteries, mostly, for example, if it's the coronary artery that has been affected, you're going to have ischemia to the organ. If the ischemia to the organs, for example, the coronary arteries have been occluded, you're going to have reduced blood supply to the myocardium and it will die of leading to infarction. If it is the brain, you say cerebral infarction. If it is the heart, you say coronary or ischemic heart disease or coronary artery disease. If it is the lower limbs, you're going to have ischemia to the lower limb, and that will lead to claudication, of which claudication is that feeling where you just move a bit, you feel tired. Feel a bit, you feel tired. You just walk a bit, you feel tired. You want to try something, just feel tired. Not that tiredness of what, but something is just trying to like resist you from doing the whatever that you are trying to achieve. So claudication, you feel pain whenever you just try to do something, just do a little effort. During exercise, for example, you just feel pain. And this is usually caused by a decrease in blood flow. That is claudication or claudications. So it's just that pain that you feel in the legs because you just want to move a bit, you want to try exercising, you just feel that. Or because the small arteries of the limbs have been obstructed, you're going to have an infarction or what is called the gangrene, also called dry gangrene, because it becomes very hard and black and there's no blood reaching there. So it dies off and it is called the gangrene. Okay. So now we can talk about ischemic disease without talking about atherosclerosis. And that is going to be the second video. Let me pause this one so that you watch it and enjoy it. Thank you so very much. We'll have a chance. Bye.